Thank you, Laskin Corla. I move that the Health Regulation of Termination of Pregnancy Bill now be read a second time. As legislators in our national parliament, we hold a very privileged position, and never more so than when we are acting on the instruction of the people in a referendum. On May the 25th, the Irish people gave us a very clear message to legislate for the introduction of abortion services in this country. Today, we begin the job they have given us of making the law that follows the repeal of the 8th Amendment, and after 35 years in our Constitution, in doing so, we are also making history. Of course, history is not only made in this House. This history was made on the streets, was made in homes, and was made in ballot boxes right across this country. It was made by people, including colleagues here, who have campaigned steadfastly for many years. By young people who had never had a say on an issue they cared deeply about and who were galvanised by a movement for equality. It was made by everyone who thought deeply and felt strongly on this subject in their different ways and came out on the 25th of May to make their decision known in the ballot box, resulting in an emphatic majority to repeal the oppressive, repressive 8th Amendment and for us to get on with our jobs and legislate. It was a resounding affirmation of respect and support for women and their right to make choices about their own lives. It was a reaffirmation of the primacy of equality in our modern democracy. And it was also a call on us to do more on women's health, on women's equality, more on continuing to shape an inclusive and equal society. As Minister for Health, after all we heard during the campaign, after all I've learned since I took this role, after everything we know of the dark past, I am determined that today, now, we begin a new chapter on women's health. A chapter in which women are valued, their decisions are respected, and they are cared for without judgment. This will be a priority for me in the time ahead. I now turn to the legislation before us. The main purpose of the Health Regulation of Termination of Pregnancy Bill is to set out the law governing access to termination of pregnancy in this country. The legislation permits termination to be carried out in cases where there is a risk to the life or of serious harm to the health of the pregnant woman, where there is a condition present which is likely to lead to the death of the fetus either before or within 28 days of birth, and up to 12 weeks of pregnancy as set out in Head 13 of this legislation. I will now take you through the bill to clarify its provisions. I want to note from the outset that while the bill is now arranged slightly differently, its key provisions are the same as those of the draft general scheme approved by government, which I published in March ahead of the referendum, and indeed of the updated scheme approved by the government and made public in July. And I think that's important because it provided the people of Ireland with an opportunity to make an informed decision, knowing what our intention would be in terms of the law if the referendum was passed. The bill is now divided into three parts. The first part of the bill has sections on definitions, on regulations and offences under the bills, on repeals and transitional provisions. Section 1 of the bill makes standard provision setting out the short title of the bill and arrangements for its commencement. Section 2 deals with definitions. It defines the meaning of some of the terms used for the purposes of the bill, including fetus, medical practitioner, medical procedure and termination of pregnancy. Section 3 deals with regulations, allowing me as Minister to make regulations to bring the legislation into operation and other such procedural matters. Any such regulations will, of course, have to be laid before the Houses of the Oireachtas for approval. Section 4 allows that approved expenses associated with the administration of the bill may be paid for from public funds. Section 5 sets out the substantive offences under the bill. It provides that it shall be an offence for a person by any means whatsoever to intentionally end the life of a fetus otherwise than in accordance with the provisions in the bill. These provisions will not apply to a pregnant woman who has ended or attempted to end her own pregnancy. We never criminalise the woman. It is further an offence for a person to aid, abet, counsel or procure a pregnant woman to intentionally end or attempt to end the life of the pregnant woman's fetus other than in accordance with the provisions in the bill. The penalty in the bill for intentionally ending the life of a fetus otherwise than in accordance with the provisions of the legislation is on conviction a fine or imprisonment for up to 14 years or both. It should be noted that nothing in the bill will prevent or restrict access to services lawfully carried out outside of the state. This means that, for example, a doctor referring a patient to a service abroad, or a person paying for flights or accompanying a woman to another jurisdiction to access the procedure, they will of course not be committing any offence under the legislation. Section 6 of the bill provides for the offence by a body corporate. Section 7 repeals certain laws which are in contravention with the principle of the bill. In particular, it repeals the Information Act. And I want to make it clear on the floor of this House today that I hope to be in a position to commence this particular part of the legislation as soon as the law is enacted, so that women who are having to travel whilst we're waiting to introduce the new services in January can at least have the opportunity for their doctors to share information with doctors abroad. And I know from talking to women and talking to women's groups, this is something that would be of vital assistance in the interim. Section 8 puts arrangements in place to cover situations where a review committee has been convened under the Act of 2013 and is ongoing at the time that the present bill comes into effect. It also obliges the HSE to prepare and submit a final report on reviews to me as Minister, not later than 6 months after the commencement date of the present legislation. Part 2 of the bill covers the grounds on which terminations of pregnancy may be lawfully provided under the legislation, arrangements for conducting reviews and provisions on certification and notification of procedures under the legislation. Section 9 offers definitions on health, appropriate medical practitioner, medical specialty, relevant specialty, obstetrician, review committee and viability. Sections 10 to 12 of the bill set out the grounds on which termination to pregnancy may lawfully be provided where there is a risk to life or of serious harm to the health of the pregnant woman, where there is risk to the life or health in an emergency, and where there is a condition likely to lead to the death of the fetus. Section 13 provides that a termination of pregnancy may be carried out by a medical practitioner who, having examined the pregnant woman, is of the reasonable opinion formed in good faith that the pregnancy concerned has not exceeded 12 weeks of pregnancy. A 3-day period must elapse between certification and the procedure being carried out. This requirement is not unusual. Indeed, several countries in Europe, including Belgium, Germany, the Netherlands, Italy and Luxembourg, have similar provisions. The certifying doctor must then make arrangements for the procedure to be carried out as soon as possible once that period has elapsed. Sections 14 to 19 of the bill set out the arrangements for reviews of medical options, where this is sought by a pregnant woman or person acting on her behalf. The purpose of the review process is to provide a formal mechanism whereby the woman can access a review of the clinical assessment made by the original doctor or doctors. I should make it clear that the formal review pathway is in addition to, and not in substitution for, the option of a woman seeking a second opinion, as is normal with medical practice. Section 14 states that where a medical practitioner has not given an opinion or has not given an opinion which would certify a procedure being carried out under Section 10 or 12, he or she must inform the pregnant woman in writing that she or a person acting on her behalf may apply for a review of this decision. Section 15 provides for the establishment of a review panel by the HSE, which may be drawn upon to form a review committee. Section 16 deals with the establishment of the review committee. As soon as possible, but not later than 3 days after receiving a written request from a pregnant woman, the HSE will convene a committee drawn from the review panel to consider the relevant decision in question. Section 17 specifies that the committee shall complete its review as soon as possible, but not later than 7 days after it's established. Section 18 sets out the procedures for the review committee. It aims to empower the review committee to obtain whatever manner of clinical evidence it requires to reach a decision, and to call any relevant medical practitioner to give evidence. Section 19 provides that the HSE must submit a report to me as Minister for Health not later than the 30th of June each year on the operation of review committees. Information that will have to be provided in the report includes the total number of applications received, the total number of reviews carried out, in the case of reviews carried out, the reason why the review was sought, and the outcome of the review. Any information, of course, that might identify a woman who has made an application for review, or a person applying on her behalf, or a medical practitioner involved, shall be excluded from the report by the HSE. This information is required to monitor the implementation of the legislation, to ensure that the principles and the requirements of the system which this House will, I hope, vote to put in place are being upheld. Sections 20 and 21 set out requirements under the legislation around certification and notification of procedures carried out under the bill. Section 21 also contains a requirement for me as Minister to prepare and publish an annual report on the notifications received. And again, this will be done without disclosing the names of the women or the medical practitioners involved. The third and final part of the bill, Laskin Corla, includes provisions covering consent, conscientious objection and provisions for providing universal access for services for persons ordinarily resident in the state. Section 22 deals with consent and states that nothing in the bill will affect the law relating to consent to medical treatment. The intention is that the provisions in this bill will operate within the existing legal provisions regarding consent for medical procedures. Section 23 of the bill covers conscientious objection. It states that where he or she has a conscientious objection, a medical practitioner, a nurse or a midwife shall not be obliged to carry out or to participate in carrying out a termination of pregnancy. This is not new because it's in line with Section 49 of the Medical Council's Guide to Professional Conduct and Ethics for Registered Medical Practitioners 2016, which obliges doctors to enable patients to transfer to another doctor for treatment in cases of conscientious objection. Section 24 prohibits receiving financial or other benefits in kind in cases where referrals are made to services providing terminations of pregnancy. It states that a person shall not receive or agree to receive any special benefit or advantage in consideration of a termination of pregnancy within or outside the state, or for making any arrangements for termination of pregnancy within or outside the state. A person contravening this section shall be guilty of an offence and liable on summary conviction to a Class A fine. The aim of this section is to protect a woman's interest and to ensure that she receives objective advice and information uncoloured by any financial or other considerations. It will ensure that the person or body cannot derive any benefit from recommending that a termination be procured, with benefits to include financial incentives, as well as any other types of advantages or benefits in kind. Section 25 to 27 of the bill provide the legislative basis for providing universal access to termination of pregnancy services for persons who are ordinarily resident in the state. This is so important. We cannot have a situation where a woman cannot access the service owing to cost. We want to provide this as part of the Irish Public Health Service and an integrated part of the Irish Public Health Service. Section 28 of the bill amends the schedule to the Bail Act 1997 to include an offence under the bill. I would now like to turn to what the service would look like should this bill become law. The bill allows the service to be provided in the primary care setting. It is my intention that termination of pregnancy services should be provided as part of the continuum of women's health services. This would mean that in the future, women would be able to choose to have this service from their own GP, from a person with whom they are comfortable and familiar. The international evidence and advice I have received shows that most women can have their care provided safely and effectively in the community setting. This is particularly the case where the service is carried out in early pregnancy. The evidence shows that the earlier in a pregnancy that a woman seeks the service, the safer it is to provide it without recourse to hospital treatment and with minimal complications or other risks to her health. Officials in my department and the HSE are at an advanced stage in drafting contract proposals to allow for as many members of the general practitioner community as possible to participate. I look forward to a high rate of participation among general practitioners so that women's access to the service at this stage in pregnancy, when it is safest, can be facilitated. So up to 9 weeks gestation, it is envisaged, as I have said, that most terminations will take place in the community setting and without recourse to referral to hospital or ultrasound scans. I do understand, of course, that not every woman will present early in pregnancy and during the first 9 weeks. In situations where women present between 9 and 12 weeks of pregnancy, the international evidence and advice that I have received indicates that GPs should refer women to the care of a consultant obstetrician in a hospital environment. Terminations after 12 weeks of pregnancy will only take place on the grounds of a risk to the life or health of the pregnant woman, a risk to the life or health of the pregnant woman in an emergency, or where there is a condition likely to lead to the death of the fetus before birth or shortly thereafter. These will occur in a hospital setting. I understand that detailed work is ongoing under the auspices of the relevant medical colleges to develop more detailed clinical guidance to assist practitioners in the clinical decision-making involved in dealing with these women in these situations. My department has provided financial assistance to the colleges to enable them to complete this work as a key component of the delivery of an integrated service. I was very pleased yesterday to welcome the appointment of the eminent Dr. Peter Boylan to assist with the HSE's preparations for the implementation of arrangements for termination of pregnancy and related services. Dr. Boylan is a leading figure in obstetrics and gynecology, and we are so pleased to have him assist in this work. He has a long track record as a women's health advocate and an expert clinician. I very much thank Dr. Boylan for agreeing to undertake this work. Following similar models in other countries, I have directed that the HSE make arrangements to put in place a medically staffed national telephone helpline to be available on a 24/7 basis once the expanded termination of pregnancy services are in place. My department and the HSE are collaborating on developing a comprehensive plan for communicating with the general public and with stakeholder groups for use in introducing expanded and new services. Messages to the general public will highlight the pathways to accessing services, sources of crisis pregnancy counselling and information where the woman may wish to access them, and medical information on the procedure at different stages of gestation. The importance of attending services early will be one of the key messages of any communications plan. I want to reiterate that the Government is also committed to working to reduce crisis pregnancies by improving sexual education and ensuring that cost is not a barrier in accessing contraception. The very important ancillary recommendations of the All-Party Committee need to be acted upon by all of us in this House. We need to help reduce the number of women who find themselves in a crisis pregnancy, as well as expanding termination services. Lasceann Comhairle, it has been a long road, indeed a very long road, to get to this juncture. I think today of the many people who have fought this battle for women's rights and women's equality over the past 35 years. I think of the women who shared their private, their most intimate experiences with the Irish public in order to seek change. I think of the women and their families who have endured hardship and pain as a result of the 8th Amendment, but felt unable to share their stories. I hope the work we begin today and the referendum result sends to them a message of solidarity and support that they were left long without. So in closing, I would ask that we continue to be constructive and not obstructive in this House, and that we ensure we are respectful of each other and of the views of the people of this country, the people who have voted and made their decision, as we start the debate on the health regulation of termination of pregnancy bill. I hope that we can work together constructively on this legislation so that we don't rerun the referendum campaign. That argument is dealt with. Those votes have been cast. But instead we work together to put services in place for women who need them as soon as possible. The voices of women who spoke up so movingly during the referendum campaign earlier this year cannot ever be unheard. Their stories can never be untold. If, as I believe to be the case, the people decided they could no longer countenance women being denied care in their own country, then we have to make that change. Lasceann Comhairle, it is time to end the lonely journeys. Time to finish lifting the shame and the stigma that have cast shadows on so many lives. It is long past time to stop punishing tragedy. I look forward to an Ireland where any woman facing a crisis pregnancy can be assured that she will be treated with compassion and will be able to access all the care she and her family need in this, her country, supported by those who love them and care for them. That is the objective of this bill, and I commend it to the House.